Longevity Junky is presented to you by our friends at Acast. Hello, Longevity Junky. It's time for you to get your fix. I'm Nikki Leigh.
I'm Joffrey. On this week's show, we're going to talk about something called long COVID. That's different from the COVID that you probably think of when you hear the word COVID. Most people are definitely not aware of what long COVID is, but it's something that could be affecting up to 7% of the population in the United States. Nikki and I feel it's really important for you to know about. On the other hand, we also understand that these kinds of shows sometimes can be charged. COVID itself has become a politically charged issue. People have strong opinions about vaccines, and there's strong emotions about the lockdowns we all experience. But that's not what this show is all about. We're going to talk about long COVID because this is something that's an entirely different disease from the acute COVID infection that we've all heard about and experienced. The reality is that many people who contracted COVID, whether they had mild or severe disease, are now dealing with lingering mysterious symptoms like chronic fatigue and brain fog. And some may not even realize what they're experiencing is actually long COVID.
So in this episode, our goal is to raise awareness about long COVID and offer guidance for those who may be suffering from it, perhaps unknowingly. You might even know someone experiencing these symptoms and struggling to figure out what the cause actually is. The good news is that treatments are available, and we just want to help spread that information. So please listen in to our interview with Dr. David Putrino, as this episode could help you or someone you care about who's been dealing with this frustrating and often misunderstood condition. Time for a special on long COVID in the breakdown. Our guest today is Dr. David Putrino. David is a physical therapist with a PhD in neuroscience who studied computational neuroscience at Harvard Medical School, MIT, and NYU. He is currently the Director of Rehabilitation Innovation for the Mount Sinai Health System and a professor in the Department of Rehabilitation and Human Performance at Mount Sinai. He is also an official medical provider for Red Bull-sponsored athletes in North America and the chief mad scientist of Not Impossible Labs, providing accessible technological solutions for high-impact humanitarian problems. David's research has been featured on ABC, Sports Illustrated, The Wall Street Journal, the BBC, Time, Wired, and the LA Times, to name just a few. David, welcome to the show. Darn, you got a lot
David.
going on.
Yeah, that's it for today's show. Thank you very much. And
I like to keep busy.
I love it. So tell us how you got involved with long COVID patients.
In 2020, when the pandemic hit New York City, our team, got to work. We were in pretty desperate times, and we were running out of hospital beds, and it was a really rough time. Mm. People would come to the hospital and say, I think I have COVID. We would test them. They would test positive. And then we would kind of say, well, you walked in here. You can probably walk out. You're not sick enough to take up a bed right now because we're really short on beds. We were concerned about that because how much worse should you get, before you come back to the hospital, and what symptoms should we be looking out for and all that sort of thing. So, my team does a lot of work with technology in healthcare. And so we quickly put together an app that could monitor symptoms of respiratory dysfunction. We sort of put a broad message out to all of the emergency departments in all 8 hospitals of the Mount Sinai system. And we said, if anyone goes home with COVID, send them home with this link and we will take it from there. We will monitor them every day. If they don't have a smartphone, we'll call them, and we will just make sure that they're doing okay. Sure enough, New York being New York, by the end of March, we had 7,000 people on the app. By the end of April, we had tens of thousands of people being monitored. And what we started to notice by the end of April was that around 10 or 15% of the people that we were monitoring acutely weren't leaving the app. They weren't talking about fever, but they were talking about, I can't get my groceries up my stairs. If I do, I have to crash for a whole week afterwards. And I can't think the same way I used to think. And, all of these symptoms that we now know to be terribly familiar. Long COVID wasn't a term then. We started calling it post-acute COVID syndrome because that was what it was. It was, we didn't want to say that it was post-COVID because maybe COVID was continuing in these people. But it wasn't the same as acute COVID. So we said, okay, post-acute. It wasn't anything that we could measure. So it was a collection of symptoms, which is a syndrome. So we said, okay, post-acute COVID syndrome. And then we started hearing from other people around the world. There was a patient who first coined the term long COVID, Elisa Pereggio from Italy. We started hearing that people were calling it long COVID.
How would you define long COVID?
The way that we define it is very simple to be inclusive. Anyone who's survived an acute COVID infection and 3 months later, they still don't feel like they're back to their old self, that person has long COVID. I think that is a really good definition. The National Academies of Science, Engineering, and Medicine just really released that as the definition that we should be following, and they did that this year in 2024. While we're still working out exactly how to diagnose this thing with biomarkers and be very specific about a diagnosis, it still allows us to say, if you're not feeling well, we're going to count you because your experience matters.
So obviously we have we're distinguishing between acute COVID, which, the COVID disease itself, and then what you guys initially called acute, the post-COVID syndrome or whatever. Now we're calling it long COVID. What exactly the, pathophysiology, what is going wrong in long COVID that makes people have this disease that is separate, a very distinct disease from COVID itself?
This is a complicated topic that has been really well written about by the journal Nature. Has put out a few really wonderful narrative reviews talking about the different drivers of pathology in people with long COVID. Here is the thing to remember is that not necessarily everybody with long COVID, because we've been so broad with the definition to make sure that no one's left behind, not necessarily everybody with long COVID is going to have the same thing going on in their bodies. Some people with long COVID, a lot of the pathobiology and pathophysiology that is driving their symptoms is autonomic nervous system dysfunction. So our autonomic nervous system is this wonderful sort of subdivision of our nervous system that controls all of the things that we usually don't need to think about. How quickly our heart should beat, when our body should be digesting food, when we should be sweating to control our body temperature, all of this stuff that you don't need to think, hey, start sweating now because my body temperature is creeping up a little bit. No, our body figures it all out. It's very intricate, it's very delicate, and it can be knocked out of balance.
There was at some point, I remember some thought that there was some persistent particles, COVID particles or DNA remnants, things like that were potentially to blame for some of these symptoms. Has that theory been sort of flushed out? Or
we actually published a peer-reviewed article on this in Nature Reviews Immunology. There is a robust body of literature now showing very clear evidence that in at least a subset of people with long COVID, there's not just persistence of the virus, persistence of antigens, so parts of the virus or proteins related to the virus.
Like dead virus, right? Like dead virus, yeah.
There is dead virus or partial virus. However, it is still causing, and a lot of the studies that we cite, it's still causing active immune reactions and influencing even right down to some of the ways that our genes are expressing themselves in the tissue around the viral antigens. There's also some very compelling data that Michael Peluso's team on the West Coast has published showing evidence of live virus persisting inside of the body. There's an increasing body of evidence to suggest that people with long COVID may be experiencing persistence of live virus as well as persistence of, antigens and partial virus. And if you think about it, it kind of makes sense. People get funny about talking about viral persistence. COVID as a virus is not supposed to persist. All of the virologists at the time told us, no, coronaviruses don't persist. They're not like, herpes viruses and things like that. But, if you take away that knowledge, if you're just like, look, let's start from a clean slate. This is a new virus and we're just going to start from a clean slate. And then I tell you that, well, there's some people who recover from SARS-CoV-2 infection and there's some people who don't. And in the people who do recover, we don't see all of these bits of viral fragment and partial virus and so on and so forth. And in the people that don't recover, we're seeing all of this stuff. A really good explanation for that, given that we're seeing it 8 months down the track, is that there's live virus somewhere. And then, the partial virus and the broken up bits of virus that we see in the blood tests that we do are indicative of a larger reservoir somewhere else.
Just for the audience, I think it might be an interesting parallel here. When kids getting chickenpox, well, they get varicella vaccines these days, so a lot of kids don't get chickenpox anymore. But the idea behind, some later diseases that people are getting is essentially recurrent chickenpox virus. Varicella, even though you treat the chickenpox, it essentially stays in your nerves at some point in a latent way and eventually can come back and create a disease that's very similar and probably more serious in the elderly. And the same thing goes for various types of herpes viruses. So the reason I'm bringing these up is what you're talking about is a situation where you may have, it could be in the nerves from what you're talking about, is essentially be a reservoir, like the autonomic nervous system could be a reservoir for this virus, and that is somehow, then you would expect it to wax and wane though, wouldn't you?
Yes, and many people with long COVID experience relapsing remitting symptoms. I also do want to point out the fact that we've found, we published a paper late last year showing that individuals with long COVID are much more likely, compared with healthy controls, to be experiencing reactivation of other viruses in their body. Epstein-Barr virus, herpes viruses, CMV, these were all reactivating in the bodies of people with long COVID and not reactivating in the bodies of our healthy controls and our convalescent controls. And so, overall, in addition to viral persistence, it's very clear that something is happening to our immune system. We called it, the concept that we framed around it in the paper was what's called immune exhaustion. So it's not immunodeficiency like you would see in HIV. It is an exhaustion of the immune system because it's fighting so many things that some of these opportunistic viruses start to, reactivate. And then we also put out some data just around the middle of this year that is under peer review right now, but is available to view online as a preprint, where we actually completed what's known as our first passive transfer trial, meaning we took immunoglobulin, which is just sort of like an antibody from the blood of people with long COVID, and we took it also from the blood of healthy controls, and we injected those antibodies into mice. And the mice who received antibodies from the healthy controls were totally fine and performed well on all of the testing that we were doing. And the mice that received the antibodies from the people with long COVID within 6 days developed issues with muscle strength production, developed balance issues, and developed chronic pain issues, started to develop pain syndromes. So this is also telling us that something's happening in the immune system, that we're producing what are known as functional autoantibodies, antibodies that attack tissues within the body. And, and that is transferable. We can actually give that to an animal and the animal will get sick.
So I had never heard of this long COVID. So I just started to do some research on this. And one of the things that I found was that that people who, that work out, they have muscle soreness and we understand that. We understand that after you work out, you have a muscle soreness after a couple of days and things like that. But there were people who were with long COVID and they were having even more extreme soreness and even to the point where, like you were saying, they can't get upstairs or carry their groceries or something. And they even said that they felt like they were literally poisoned. And then the then the article goes on to say that the mitochondria was actually affected. And that's the energy of the cells. And then it also went on to say that if the mitochondria can get infected and, altered, then it's actually something we have to worry about, that possibly the brain too can also become a victim of this. And so with all that said, I'm also just trying to figure out what exactly are the symptoms that come from this, or that people are reporting exactly, to maybe allow someone to realize sooner rather than later that this is long COVID other than something else.
That's a great rundown of what a lot of people are experiencing. And I would say that first and foremost, one of the most common symptoms of long COVID, by far 90% of the people who come to our center will report this symptom. It's called post-exertional malaise. So sometimes also called post-exertional symptom exacerbation. But in general, it's almost exactly what you're describing, Nikki. It's that they will exert themselves and pay for it afterwards. So anything that requires an energy exertion. So the most relatable is, of course, physical exertion, but this can also go for cognitive exertion. We have a lot of folks who, they were lawyers, they were engineers, they sat behind a computer, they can't look at a computer anymore, so cognitive exertion can do it. Emotional exertion can do it. Even, believe it or not, we have folks struggling with things like digestive exertion. So, they got long COVID. They started to think, okay, I'm going to get really healthy. I'm going to fix my diet. So they're eating this high fiber diet and, good proteins and everything. And that takes a lot of energy to digest.
Yeah, a lot.
And so they crash after eating, whereas if you give them, a slice of white bread, which is cheap energy, right? It's really easy for your body to break down white bread, or simple carbs. They get consequence-free energy, or near consequence-free energy. So even something as simple as expending energy on digestion can really knock you back for a few days. Post-exertional malaise as a symptom is tightly linked, we believe, to mitochondrial function. And there's a wonderful researcher by the name of Rob Woest in the Netherlands. He did a study that was published this year where he showed that if you took healthy people without long COVID and people with long COVID and you got them to exercise to failure, muscle activity to failure, the next day you took muscle biopsies and muscle samples of the healthy controls and their muscles were fine. When they looked at the muscle of people with long COVID, they were seeing proteins associated with mitochondrial dysfunction, littered through the body. And to your point about the brain, Nikki, some of those proteins are called, amyloid proteins, which are exactly the biomarker we see in Alzheimer's disease, which we also believe to be a disease of energetic dysfunction in the brain. And so, this really does make you think that the mitochondria are very central to a lot of the pathobiology and a lot of the, potential treatments as well.
Wow.
I would also say that what we're seeing is, depending on the paper you read, 60 to 70% of the demographic of people with long COVID tend to be women. And we recently, we recently published a paper about this with our colleague Akiko Iwasaki from Yale University. Women being more likely than men to get long COVID seems to be related to hormone availability and specifically testosterone levels. So testosterone appears, we still need to do more research on this, appears to have a protective effect. And so men with high testosterone levels are less likely to express significant long COVID symptoms.
So would women need to maybe take more DHEA?
This is a really good point, and this is where we're looking into hormone therapies. When it comes to hormone therapies and hormone supporting therapies, I tend to very strongly believe that a personalized approach is needed because often, it's like, okay, your testosterone's super low, but also your estrogen's really high and, progesterone's somewhere in the middle. And We need to figure out how we're going to navigate that in a way that pumping DHEA or testosterone into the system isn't going to get it done.
Mm-hmm.
But we are starting to see some initial signs that working on the hormone imbalances really can affect people's overall symptom burden and make them feel a little better. It's not a cure, but it is something that can dial the needle on some of this.
You know, this topic is so confusing. Even when we're talking here, I'm sitting here trying to, you know, in my doctor way, trying to put this together and trying to create sort of a meaningful story, you know, and what I'm getting here is essentially there is some interplay between the immune system and the autonomic nervous system. And in that regard, I guess the question is why the autonomic nervous system? Why, you know, presumably the vagus nerve is involved here. Why is there any sense of why that would be a preferential target of this virus?
It's a good question. There's some dueling theories around this. There was a really great paper that really just talked about the fact that SARS-CoV-2 loves the gut, and the vagus nerve is lining the gut. And so the virus, as it sort of digs into gut tissue, also digs into nervous tissue. And this one paper showed very, very clearly that SARS-CoV-2 can literally just from the gut scale its way all the way up to the brainstem via the vagus nerve.
Oh my God.
Wow. So just going backwards and all the autonomic nervous system in the gut, sort of just scaling backwards on those nerves all the way backwards.
Exactly.
That's crazy. And then what about the central nervous side of this? Obviously, there's a large component of cognitive impairment as well, which I don't know that we've touched on as much. It might be worth diving into a little bit there.
No, absolutely. And, you know, again, our approach clinically is that we always try to very holistically evaluate someone when they come into the clinic, because there are many reasons that you might have cognitive impairment after your infection. And if we get the wrong one, then we're not going to help you, you know. So there are no blanket treatments. You know, people are always like, what's the 3 best things I can take for long COVID? And my awful response is always like, it depends, you know, like it depends what's happening in your body. But, you know, so to that end, cognitive impairment can happen because of POTS. A lot of people will experience cognitive impairment because their brain is not getting blood when they're upright, you know, and we can measure that. We can measure that with a tilt table test. We can measure that with a technology called transcranial Doppler, where we actually measure how much blood is making it into the brain using an ultrasound technology. You know, and that's something that can tell us if you have POTS that is affecting your brain's ability to get oxygen. And if you do, you know, we usually start off with some very simple, you know, first line interventions. So things like compression garments, hydration, etc., you know, like electrolytes and rehabilitation. We can then move into some sort of like more mid-tier, interventions, things like vagus nerve stimulation, which you sort of clip a little thing on your ear and you stimulate the vagus nerve, or things such as stellate ganglion blocks, which is a small procedure that can downregulate some of the sympathetic nervous system activity that you're experiencing. And then, we can also try out medications. There's a drug called midodrine, which can increase blood flow to the brain preferentially. And, in people who are experiencing reduced cerebral blood flow that causes their cognitive impairment, sometimes these interventions are just rescue interventions. They go from feeling like they can't do a single thing cognitively to they're just back at normal. And especially you'll sometimes see it with the hydration most aggressively, because it's so transient that you hit them with a lot of electrolytes and they come back to life, and it lasts 2 or 3 hours, and then they feel themselves flagging and they need to replenish the electrolytes. So that can be a cause of cognitive impairment. Another big cause of cognitive impairment is neuroinflammation. And we've published a number of papers showing the effects of different cytokines and chemokines on nerve tissue specifically, and the fact that even if you have a very mild SARS-CoV-2 infection, it can still produce chemokines that get into the brain and start causing activation and damage to brain tissue. And so it's a very scary thing to think about. Myself and my friends and all of my colleagues who are researching long COVID, we're still very aggressive about wearing masks everywhere and really trying to avoid infection because, after seeing the data that we're seeing, it's really hard to brush off even a mild infection.
I would say that I am no different in that, most of us at this point think of COVID as something of the past, right? We're not really, COVID, at least acute COVID infection right now is no worse than getting the flu. But I guess the point that you're raising is an interesting one, is that you might not worry so much about the acute issues around COVID because, maybe you end up with a mild flu or whatever, and you're going to get over that. But has the incidence of long COVID gone down?
No, it really hasn't. And that was actually one of the very concerning things about our public health messaging around, these issues is it's funny that Dr. Mandy Cohen from the CDC director, she said almost exactly what you said, Buck. She said, getting COVID is no different from getting the flu. She said that on the day that they said that COVID is no longer a national emergency. On that same day, the CDC, her own institution, also released a memo saying, according to the latest Household Pulse survey, which is a random sampling of households across America, 7% of the population now have long COVID. And 25% of that 7% have it so badly that they can no longer work, which obviously is not statistics that we're used to hearing about with the flu. So,
right.
So yes, the acute sequelae of COVID, your chance of dying, your chance of being hospitalized, may be lower now. It's still, still killing more people than the flu on a daily basis. That's, that's just facts. But your chance of long COVID, your chance of a post-acute viral sequelae is still much, much higher than what we see with other viruses, that we've lived with for generations. And
but it's possible to have the long COVID be more intense than the initial COVID that you had?
Absolutely. We've had folks with long COVID, who really thought that their acute COVID infection was unremarkable until, a lot of the people who had very mild acute COVID, their long COVID symptoms didn't hit them until they were like, okay, I think I'm good now. I'm going to go for a run. Or, there was this like,
oh,
they were good.
Until
then
they had an
this
exertion of energy.
And then, boom, they sort of went down and they couldn't recover from it.
How do you differentiate long COVID from other conditions with similar symptoms?
It's getting more and more difficult to differentiate, which I think is a real shame. Like my dream would have been, if we were taking this seriously, that we ramped up testing, not just for COVID, but for lots of things, right? It would be like, hey, don't you want to know when you get really terribly sick, it's this strain of influenza A, so that, should down the track you experience long-term damage from that, we know the thing that caused it and we can maybe come up with targeted therapies. Similarly, right now, the way that we differentiate is its proximity to a SARS-CoV-2 infection.
Okay.
However, we still, we have tricky cases and we have people who, sometimes don't respond to some of the things that we would expect a response to with long COVID. And we dig a little deeper and, sometimes we see tick and vector-borne illness emerge. So it's like this person who we thought had long COVID because they came in with all the long COVID symptoms and we can't seem to track it down. And then we test them for Borrelia, which is a common bacteria carried by ticks, and they're positive for Borrelia. So, what we try to do is be as scientific as possible and as objective as possible with all of our testing.
Well, do we have any blood tests that maybe can help diagnose or track long COVID?
Not as yet.
Okay.
We have a bunch of blood tests that we can use to help guide our treatments. So, for instance, we can do a bunch of hormone tests to see what your testosterone levels are doing, what your progesterone levels are doing, and make recommendations there. We have a bunch of blood tests that we can see, do you have EBV reactivation? And so then maybe can we give you a medication to dial down viral infections that are reactivating? But for diagnosing long COVID specifically, not so much. And I think a lot of that comes with the complexity of the diagnosis. Like I said, it's a broad diagnosis right now. And so I think a lot of the work that we're trying to do right now is twofold. We have machine learning models where we've published on this, where we can show with 96% accuracy from your blood, I can tell you if you have long COVID or if you're part of a healthy control group using machine learning. But the FDA doesn't accept machine learning as a method of diagnosis. And we could push for that to change, and we certainly are having some of those conversations, because I think in the short term that would be very, very helpful to just have some blood test, regardless of how we arrive at the diagnosis. If it's 96% accurate, it's 96% accurate. Let's push it. On the other side, we're also working to differentiate different subtypes of long COVID so that we can come up with specific blood tests for the specific subtypes.
Yeah, so I'm curious now that if you have a general idea that, okay, you've got some sort of dysregulation of the immune system, what are some of the most promising treatments around this? And I bring this up because just with the immune system part of it, I had done a little bit of a literature search, and it's all anecdotal, right? There's not a lot of information here saying that one drug works or another. A lot of case studies, for example, apparently some people have responded to daily Claritin, which in a way makes sense, right? Like if you're decreasing, the activity of your immune system by taking an allergy medication, maybe that will help some people. So, but in your experience, what are some of the most promising treatments that you're using right now?
Things that work right now that have evidence behind them as well, which is always really important for me, is mitochondrial supplementation. So
like CoQ10
like
type thing?
CoQ10, arginine, NAD plus patches for people who don't tolerate taking medications so well, alpha lipoic acid, nicotinamide riboside. These are mitochondrial function supplements that either improve mitochondrial function, reduce oxidative stress, which is like helping to clear out some of the byproducts of energy production. So some of the exhaust fumes that are sort of created when your body makes energy. And some of these supplements do both. So there have been a number of studies showing that these supplements, these sorts of supplements, in people with long COVID specifically, it can reduce feelings of fatigue and it can increase resilience to exertion. So you may not kick your post-exertional malaise entirely, but you may be able to just exert yourself a little more every day before the post-exertional malaise kicks in. So mitochondrial supplements, I think, are things that are working right now that are very good. And there may be many mechanisms by which you get mitochondrial dysfunction, but at the end of the day, mitochondrial dysfunction is mitochondrial dysfunction, and it can be treated with some of these supplements. Similarly, you mentioned Claritin. A lot of folks with long COVID experience significant disability because of a thing called mast cell activation syndrome. which produces a lot of inflammation and histamine release. And so antihistamines have been a godsend to many people with long COVID. There's some really good literature out there about the use of Pepcid, which is an over-the-counter antihistamine, in reducing cognitive impairment in a subset of people with long COVID, which is really encouraging. We also use mast cell stabilizers, so some of these supplements that can also just reduce. So we've got antihistamines that reduce histamine levels, but all of the histamines being released because the mast cells themselves are degranulating and causing this sort of kick up of histamine and inflammation. So we also work with mast cell stabilizers that just dial down mast cell activity as well. And that really seems to work.
A lot of allergy medication there, right? And Pepcid's for reflux, right?
H1 and H2 blockers.
Right.
So, histamine blockers, receptor blockers seem to work quite well.
And any actions like I don't know, like fasting or anything like that helps? Or
with diet, we tend to work with a nutritionist because everyone's a little bit different. Some people have gut dysbiosis, and certain foods are a total no-go. Other people have, post-viral carbohydrate intolerance, and so we need other nutritionists to go through and take out every bit of carbohydrate that's in their diet because they can't tolerate any of it. Other people have nightshade, reactions because they've got so much histamine that nightshade vegetables, things like peppers and eggplants and tomatoes, cause them to flare up. Fasting can sometimes be helpful, especially if people, just have issues after eating. A lot of people are like, hey, I get my life back because I've got this 8-hour period where I'm not eating, and so I feel great, and then I eat, and I know I'm going to crash after I eat, but at least it's at the end of the day, and I can just eat and crash. So for us, in our experience, and I don't want to step on anyone's lived experience because we're still learning, and so there could be mechanisms of fasting that just aren't coming into play just yet in our visibility, but for us, it seems to be used by patients more of a strategy of avoiding symptoms until they're in a situation where they can control the symptoms, than it is actually helping them to get to a better place. Kind of like we're really all over the map with food interventions.
I think the theory on the fasting side of it is that at least the more prolonged fasting, meaning 5 days, fasting mimetic diets, Valter Longo talks a lot about that. And there's a couple things. One is that there tends to be a lot of decrease in inflammation during those longer fasts. And then the other thing is this whole autophagy issue of potentially sort of, body eating away the junk. And then, stimulation of a little bit of the infant immune cells into action. So I don't know, there seems to be some thought on that, but, I don't know anybody who's done it either. But I had a question too, which I got to tell you, for me, so I had what I characterize as the OG COVID, because I had it back before vaccines, before we really knew what we were doing. Everybody was panicking and had no idea what was going on. And I had it pretty badly. I luckily got monoclonal antibodies quickly because I'm a physician and I asked for them. Frankly, that's the reason why I got them.
Connections.
Yeah. So, but I still was in bed for a good, 6 weeks with a home nurse and that kind of thing. It was pretty bad. I did, I was fine. I recovered from the acute COVID, but I clearly had these cognitive issues for about 2 months. And in my case, so what happened, and again, this is, I'm not going to recommend any of this because this was back in the day when no one had any clue what was going on. But a doctor friend who was seeing patients recommended that I take ivermectin. And ivermectin has since become apparently a 4-letter word in this space. But for me, it actually seemed to correlate with my symptoms going away within days of taking ivermectin. Now, I'm not really talking about, my question is really not about ivermectin or anything, but what happened next, what was funny, because a few months later, vaccine came out, and I wanted to, I wanted to move around the world and being vaccinated was a big part of that. And so when the vaccine came out, I got one of the mRNA vaccines, and I almost immediately went back into really bad long COVID type symptoms, really bad brain fog, and that kind of thing. And now when you tell me about these mice that are getting injected with antibodies from infected patients, and then they start experiencing these sort of long COVID type symptoms, it makes me wonder, should people with long COVID be getting boosters? Should they be getting vaccinated over and over again?
Yeah. You raise a really interesting question, and I'm absolutely, I'm not going to shy away from a very honest and direct answer here. We also see at our clinic, we see people that we designate as vaccine injured, because definitely people who have received the vaccine have had adverse reactions, and that has led to prolonged symptoms that have no end in sight, just like long COVID. And we also now have enough people with long COVID reporting that mRNA vaccines have really knocked them out and knocked them down. The research that we're currently doing on vaccine injury, which is as yet unpublished, and we haven't quite released the data yet because we're still, as with all sensitive topics, you want to make sure your data is on point before you release it, so that you can be sure of what you're saying. But I would say that signs point towards spike protein being the problem. And I would say that when we speak to people with long COVID about vaccination, we always want to walk a fine line, because the worst thing that can happen to someone with long COVID is a reinfection. It can really knock them around. And so infection prevention is key. Masks, HEPA filters, good ventilation, far UVC lights, and vaccination. These are all strategies for infection prevention. And in the case of people with long COVID, what we tend to do is sit down and talk to them about what has their experience so far with mRNA vaccines been, because some of them take it and tolerate it just fine. And I would say that that's probably the subgroup of people who aren't having crazy immune flares every time a spike protein is introduced into their system. And for them, A-OK, take the ones that are out there and let us know if anything changes, is kind of the posturing that we take there. For those who said, I took it and I can't possibly take it again, we do direct them toward Novavax, which is more of a traditional vaccine. It doesn't use mRNA. It doesn't, put spike protein into your system. And so far, and this is by no means peer-reviewed, this is only anecdotal, so far we've had less people coming back and saying that really knocked me around with the Novavax vaccine, which has comparable efficacy, by the way. And so for many of our long COVID patients, we tend to say, look, be safe. And if you've had adverse reactions to an mRNA vaccine in the past, go for the Novavax.
Yeah, I would point out, just as another anecdote to follow up on that when I did get a second vaccine, because again, with one, I couldn't go anywhere anyway. And I got the J&J one, and the J&J one, of course, more traditional vaccine, it didn't do anything to me, nothing negative. So to your point about the Novavax, maybe it's the same reason. You're not actually putting the spike protein in there again. So, one quick question, it's not a quick question for you, but when you see people here who've got these sort of long COVID symptoms for a year, more than a year, they actually ever see them get better?
Right back to the beginning, it depends on what's driving their symptoms. So we've seen people who, on average, the people who come to us at this point, by the time they find us, by the time they get an appointment, by the time they get seen by us, on average, our data says that they've been living with long COVID for 2 years. That's kind of the average number. Our data at this point, our outcomes data at this point, drives us toward the idea that 20% of the people who come through our clinic will, at the 100-day mark, so after about 3 months of working with us, they will report complete remission. Thanks very much. I'm great. This has turned me around. I'm good. Now, I always say we'll report because, they could be one more immune challenge away from coming back and saying, I feel terrible. We don't know. That we don't have those follow-up data, but they could be a reinfection away from coming back and saying, I'm back at square one. I do remember one anecdote of one such person who was incredible. She then fell pregnant and triggered her immune system, and we had to work with her again, and she recovered quite well the second time around as well. But that, her immune system changing as through the pregnancy process led her to have these, a reactivation of long COVID symptoms. So, but at the very least, at the 3 month mark, a lot of people sort of leave and say, I'm feeling great. Thank you very much. By far the biggest chunk, sort of 65, 70% of the people who come to the clinic, we can double their activity levels. We can halve the number of symptoms they're experiencing. And those numbers are the data at the 100-day mark. So they're doing twice as much as they used to do. They're experiencing half as many symptoms as they were in terms of just the raw number of symptoms. And in general, they're just able to do a little bit more, and it's a process, but, they're not feeling as though they are the person they were before they got infected. They're just doing much better than they were when they came in the door.
We're going to take a break, and we'll be right back with David Putrino. Welcome back to our long COVID special. Back to our interview with David Putrino. So if somebody has long COVID, what should they do?
The first thing, and this is, I understand right from the outset how ridiculous this is try to find skilled care. Don't, at this stage where we're not really sophisticated enough that you can walk into just any old PCP and say, I have long COVID, what do I do? You're coin flip likely to get very good advice versus very bad advice. This is not a dig at PCPs. They're doing their best. And, there's not been a coordinated effort to educate the country's PCPs on this. And they're doing their best. But, you really don't have a good chance. Your best chance is to go to a specialized long COVID center. If that specialized long COVID center is immediately asking you for massive amounts of cash and saying, hey, try cognitive behavioral therapy and exercise, run.
Screaming good warning.
From, and find another specialized long COVID center. But I also understand how privileged that information is. I understand how hard it is to find centers. We're a center that's been operating since the crisis started, and we've been very strict on the fact that we don't take self-pay, we take insurance, we take, Medicaid, Medicare, we have a wait list for uninsured patients to be seen pro bono. But that's very unusual for a long COVID clinic. We're seeing more and more of our really good long COVID clinics turning cash only. That should be a warning sign to America, to Congress. And we should be doing more to making a lot of long COVID treatment accessible, because right now it's kind of an empty thing for me to say, seek out a long COVID clinic, because a lot of people don't have that capability.
Yeah, they're not everywhere. And I guess along that lines, the question would be what efforts are being made to, say, for example, I'm a physician, right? And I say, gosh, this is a problem a lot of people have. I really need to understand this better. where do physicians turn to right now to get the same information, maybe to provide the same opportunities in their community that they're getting at Mount Sinai or somewhere, the big cities where they have the resources for this?
We're a part of many efforts to sort of educate and get that education out there. I think, Buck, I mentioned to you that I'll be spending some time in Santa Barbara just for that reason. Local government has decided that it's a priority to get that education to some of the health systems in Santa Barbara. So, we're going to come out and we're going to share everything. These are the assessments. These are the billing codes. This is what we say to insurers to get insurance coverage. This is how we get it done. Because I just think that that's the sort of practical education that's needed. Because it's not that people don't want to help. It's just that, it took us 4 years to figure this out. And, we were fortunate enough to have, grant funding and donor funding to figure it out, and so now what we're trying to do is scale the program and share the information freely with as many people as we can. In the meantime, there are educational resources that are available out there for physicians. The American Association of Physical Medicine and Rehab has produced a wonderful set of guidelines and consensus documents that they created with patients. There's a wonderful website called Long COVID Physio, which has all of these free resources in multiple languages for people who are either clinicians or patients who just want to learn more. There's great books like the Long COVID Survival Guide that are written by patients that really give people a step-by-step on this is how to find someone in your area. These are the questions to ask. These are the red flags, to run away from if your doctor starts saying these things.
The last thing I want to ask you about is, so you also, this is slightly different, but I guess also potentially related, is that you also run a human performance center where you work with some of the best athletes and performers in the world. And you mentioned actually in your email that there are some potential links and parallels between infection-related chronic illness and longevity medicine. Can you tell us a little bit about that?
Basically, in 2016, I want to say, we started a center called Performance 360, focused on advancing human performance. So we're not a sports medicine clinic. We're a clinic where people show up and say, hey, I just want to be a better version of myself. What can we do? And we started to sort of push on this idea of longevity medicine and performance medicine. When you look at what's happening with long COVID and you both listen to the accounts of people who live with long COVID, as well as looking at the physiology, it really does feel like a disease of accelerated aging.
Yeah. You
see mitochondrial dysfunction,
right,
which leads to formation of amyloid plaques, which, as we were saying earlier, that's basically the pathobiology of Alzheimer's disease. You see immune dysregulation leading to overactive inflammation, which then leads to immune exhaustion, which then leads to reactivated viruses. Again, this is exactly what we see in folks who are aging, and a possible mechanism for why their immune systems get weaker and weaker with age, which is why medications like rapamycin are getting prescribed in longevity clinics. And also why, we're about to start a clinical trial on rapamycin for people with long COVID.
Are you finding anecdotal benefit to rapamycin?
Yes, it's the exact reason that we decided to run a clinical trial, because long COVID patients were getting it on their own. Because
Sure.
They are well-researched and resourceful, and they were saying, you should try this drug.
The other thing you mentioned was, obviously you were talking about NAD stimulators. You talked about NR earlier as well. So there's lots of parallels here. You're talking about all the drugs that I'm currently on.
Yeah. Metformin,
right.
These are all things that play with the immune system and the way that our body creates energy.
Fascinating.
And then, of course, gut health as well. These are all hitting and hormonal health, testosterone levels and the use of peptides to make people feel like they have more energy and that they can push through more things. So it has not been lost on me that a lot of the things that we're recommending for our athletes, a lot of the things that we would be using to sort of pull our athletes out of an overtraining syndrome situation, a burnout situation, these are the things that are also really coming to the forefront in folks with long COVID.
Thanks so much, David. It's been a real eye opener, and let us know when you're in Santa Barbara.
Well,
yeah,
well,
definitely.
Lovely to meet you both.
Oh, I'd love that. All right, we're going to take a break, and we'll be right back with Healthy Takeout. Welcome back to Longevity Junky. Time for Healthy Takeout.
I'm curious what you thought about this one, because you didn't know a whole lot about this problem before.
I do not.
Tell me what you think.
Well, I'm kind of in shock in a sense. I didn't know that people were still dealing with this. First of all, I didn't know what long COVID was at all. I always just chalked it up to COVID, and either it's, oh, we have another breakout or not. So this was super informative for me, and I'm so grateful for it because now I have a better grasp at it. And also I'm like astonished at how affected people are of this long COVID versus, if you just got it a mild symptom or something, or a lot of people talk about, oh, I got COVID, but it wasn't that big of a deal. It affected people so differently, but it seems that the long COVID that we're more experiencing now, it is really affecting people in a very intense way. I mean, to really have your muscles like not work for you, and for you to get super exhausted like that. And I mean, it's kind of scaring me in a way, really.
Yeah. Well, what's interesting is that, this is one of those things that's a little tricky, because with acute COVID, we know that, for many months now, that this disease and the acute disease of what we think of as COVID is really pretty mild, right? And so it's really even for people who did have their guard up more than others and who were more concerned than others, even those people are starting to relax. But the tricky thing here is that this really is like a completely separate disease. And in many ways, it's the bigger danger of getting COVID than COVID itself, right? Because if the acute COVID is generally speaking is mild, and right now it's no different than getting the flu. That's what the CDC says itself. However, 7% of the population, 7%, that is incredible to me.
Yeah,
walking around with these symptoms. So it's important, I think, to distinguish between these two things, because it might change. You may decide it may, change your behavior a little bit.
This is just such a really great episode for everyone to listen to. I mean, I think all of our episodes are for everyone, but this one in particular, that's more intense. That, like we were saying, it's misunderstood. People can just chalk it up to, fatigue, or I just had a workout and it, maybe I'm just sore. I mean, that's something that I feel like I go through a lot. I just have a little bit more of a concern if I'm going to have extra soreness or something. It's just something to be more aware of.
Yeah, it's it's another thing to worry about. Right?
I mean, I know. I know.
But, one other thing I thought that was useful, just because you know this stuff, right? I mean, how many people do you know? How many people do you know that just randomly just talk about how, gosh, I don't know what's wrong with me. I just feel so tired all the time, and all that kind of stuff. I mean, a lot of times those types of things, maybe they aren't long COVID, but a subset of those might actually be long COVID. And that could be like a really good thing for people to understand that there is a real reason for that, rather than it sort of just being in their head or thinking they're getting old or whatever they might be thinking.
Brain fog. Like, I know I've heard a lot of people talking about, like, just how they just don't feel sharp enough. Their recall isn't there. And, just brain fog is a big thing. And it's not always gonna, be a symptom of long COVID, but that is still a possibility.
Yeah. It's just something else to just keep in mind when you're trying to figure out what's going on with you. The more knowledge you have, the better. And, again, I think the great thing that we at least have some potential solutions. I know, just in terms of some of the things that he mentioned, simple things that you can literally, to get at home, right? Like Claritin, for example, seems to work for some people because it seems to decrease this inflammation, these low levels of inflammation. And then some of these things that help with mitochondrial dysfunction, like coenzyme Q10, CoQ10.
Right. Oh,
and, yeah, those are, they're some fairly simple things that, at least anecdotally, I know have made what seems to be some pretty miraculous recoveries for some people. So, and by the way, the other thing I thought was really interesting about this and important is, some people are trying to decide whether or not they want to get boosters and that kind of thing. The long COVID issue for those people who had it, that is something to seriously consider. And I appreciated the fact that, he essentially said, well, listen, maybe you'd be better off getting the more traditional type vaccine than a mRNA vaccine.
He mentioned the Nova vaccine, correct?
Yeah, that's the non-mRNA. That's the one that doesn't actually have the RNA from the spike protein. Getting technical, bottom line is Novavax acts more the way that the vaccines of our childhood, they work that way rather than, this different way that seems to potentially create more issues for some people.
I hope, everyone out there is able to, just put that information in your back pocket and honestly share this episode with people who might be complaining of things like that or are just not even aware that there is such thing as long COVID like I was. Really.
Yeah, fantastic. Well, great. You want to read us out?
Yes, I do. Longevity Junky is created by Dr. Buck Joffrey, MD, and Timothy Fonara. It is executive produced by myself, Nikki Leigh, Buck Joffrey, and Timothy Fonara. The show is produced by Pretty Fast, original music by Alloy Tracks, and we're distributed by our friends at Acast. See you next time.